So, very welcome to the next session. And this session is a little bit special, and we'll come back to that. But to lead you through it, I have my co-chair and very, very good friend forever, Goran Stankovic, and we have an extremely distinguished panel, which is able for question and for discussion. And that will be needed. So thank you very much for standing up for this. What we're doing today, or just now, is actually try to amalgamate all the information we have had around ostial side branch treatment. In this case, best management of the ostial circ. You have heard a lot of discussions during the 2 days around ostial treatment, nail the ostium, stent across, stent over, DCB, BCD, DCB here and there, a lot of information. And the truth is, we know only one thing. And the one thing we know is that one of the main caveats in PCI of bifurcation is the roof of the side branch, most pronounced in the roof of circumflex. That is actually the thing that we really should focus on in our techniques, because it's there we have the problem. And this is a problem that we need to solve for the future to improve the treatment. So what we're doing in this session is actually to having some very quick presentations highlighting some of the techniques, pro and cons for the techniques, and then after that have a voting about your feeling. What should we do? What do you feel is the best way to embark on these things? And we have actually separated this voting session into 3 parts. One is the ostial treatment of the ostial circ. The other is actually what do we do when we treat with a provisional strategy and focus on the ostial circ. What are these? And the third is 2-stent strategies, where are the caveats in 2-stent strategies and the way that actually that impair with the ostial circ. So this is the setup, and the setup is made, some of you was in the voting session yesterday. So please just scan this QR code on your phone, and then you will be led into the voting. And we'll tell you when to vote, and we'll tell you when to discuss, and we'll try to keep in time. So this is effective, spot on, focused, and running. Yeah, so thank you. And by this, I would like to open with the first presentation by Soledad Ojeda, who will actually discuss with us inverted provisional circumflex to the left main. Pro and con, Soledad.
Good afternoon, everyone. Thank you for the invitation. As previously discussed, the slide. I don't know how to pass the slide. Please. Okay. Thank you. Perfect. As previously discussed, 001 left main bifurcation lesions are a particular challenge for PCI. Although the evidence is limited, inverted provisional stenting is often chosen as the strategy of choice. The advantage of this technique is to cover totally the ostium of the circ, as we can see in the slide. Because nailing the ostium, the problem is the plaque is frequently uncovered, or the stent protrudes into the main vessel if the angle is not perfect, if the angle is not close to 90 degrees. Additionally, intravascular imaging often demonstrates the extension of the plaque into the left main, so that reinforces the idea to cover completely the ostium and even the left main. However, this technique is not perfect and has several problems because the risk of restenosis in the inverted provisional stent is higher compared to traditional crossover from left main to LAD. The sexy angulation of the circ may produce high link-like motion and the risk of stent failure and stent fracture. Stenting changes vessel geometry and alters the local shear stress. We promote neointimal growth. It's a point very important for stent under expansion because there is a high content of elastic fiber, and obviously there is a risk of damage of the LAD, that is the main vessel. The previous one, please. However, we have to optimize the circumflex ostium, and the first, please, the previous slide. We have to obtain the best result that's possible because it's a very challenging lesion, and we have to start with imaging. That is mandatory in this type of lesion because we have to confirm that the lesion is a truly 001 lesion. Most of the lesion can be reclassified after IVU. We also have to assess the plaque composition and distribution, reference diameters, and the morphology of the carina and the width of the carina sheet. Plaque preparation is another key point, widely discussed along the sessions. We have to prepare adequately the plaque. For example, in this case, we needed a rod ablation and OPM balloon guided by IVUS to make sure the plaque is good preparation for stenting. And it's clear we have to choose a right stent. The platform is important because the platform has to have a very good radial strength, and it can adapt to the side difference between the circ and the left main, and that point is very important if there is a big discrepancy between both vessels. Obviously, we have to perform a very carefully provisional stenting technique, step by step, guided by IVUS or OCT, plaque preparation, crossover stenting, pot, always pot, and kissing balloon, and final kissing balloon, depending on the result of the LAD. And finally, we cannot settle for a good angiographic result. We have to perform always an assessment by IVUS of the left main and optimize the result according to the data obtained by intravascular imaging. So, although the technique is not ideal, but the least bad alternative we have at this moment was waiting for data about drug-eluting balloon. Thank you very much.
Thank you very much for the first part of this session. Maciej, you're already ready and up and running. So, please.
Yeah, thank you, Ian. So first, when I was asked to give this talk, I was kind of annoyed that, to talk on this. But then I thought, okay, I might play the devil's advocate. But the more I dug into this field, the more I was convinced that this devil didn't need any advocate. So these are my disclosures. So there are at least a couple of anatomies where nailing the ostium is a reasonable option, like there is a large discrepancy between left main and circumflex diameter, a very unfavorable takeoff of the circ as on the second picture, but frankly speaking, you can use this technique in any anatomy, whenever you just want to keep your procedure simple, swift, and safe. So nailing the ostium is really a very short and easy procedure with low contrast volume and radiation. It's safe for both branches. There is no stent stress or deformation due to angulation and the movement of the stent during heartbeat. Of course, we avoid ostial LAD dissection and stenting, and there is literally zero risk of left main stent malapposition or deformation because there is no left main stent whatsoever. So what's the problem with this technique? Of course, everybody knows. You go either too proximal or too distal, so we just miss the point, or you protrude too much into the left main with some sequel, which is unfavorable. So my answer to this, just don't do it, yeah? And I can show you a couple of tricks. They are very old tricks. I'm not talking about Chabot technique and flower petal, but more than 20 years ago, the stent pullback technique was published, when you can really precisely position the stent at the ostium. Recently, a few years ago, the body balloon technique, you can fix your stent with the partially inflated balloon to keep it in a position. And if you still feel that your skills are not enough to this, I have a good news for you. because there is a new stent, new kid on the block, a stent dedicated just to fix the lesion at the ostium. This is the Ostfit stent, designed with the sequential opening. First, the proximal part of the balloon opens, then you can position precisely the stent at the ostium, and then you inflate the stent completely. And what about clinical data? Of course, no randomized studies, but there's a very nice large registry, multi-center, multinational. A couple of co-authors are here in this room. You see left main, which is ostial circ, is 1/3 of the population. And look at the MACE, yeah? You see there's absolutely no difference, regardless they use ostial stenting or inverted provisional, and actually the trend goes into opposite direction, favoring slightly the ostial stenting, and the only independent predictor of MACE was diabetes, not the technique itself. So let me show one case, non-ST elevation ACS. You see a very, very complex anatomy of the circ. Try to imagine stenting this crossover from left main to the circ covering the ostium of the LAD. Right coronary artery is totally occluded. So we spent a lot of time on preparation, rota, IVL, lots of calcium. You see the images, IVUS images. And by the way, you see also on the right-hand side that the left main is not significantly stenosed. So imaging, as Soledad mentioned, is very important. So after delivering with difficulty the first stent distal to the circ with the use of guide extension catheter, I position at the very ostium the second stent, just nailing the ostium of the circ, 2.528, lots of post-dilatations due to the anatomy. And now look at the result. The angiographic result is great. You see this funny dissection covered by the stent. You will see it on the IVUS as well. And I'm showing you the IVUS because you clearly see that there is some struts covering the ostium of the LAD coming from the circ. So this is something that we don't want to have, but it happened that it was like that. And look, seven months later, the patient was admitted for planned LAD diagonal bifurcation lesion procedure, and you clearly see that the circumflex is still okay, and there is no lumen narrowing, there is quite widely opened LAD, and there's a very nice long-term result of this lesion. So I think in this situation, the devil does not need any advocate, because this procedure, like nailing the ostium, is very easy, safe, and effective. Thank you so much.
Thank you so much. Thank you so much, Maciej. And Soledad and Maciej, maybe you should come up here, both of you, because what we'll do now, you can start the voting. Shall we vote too? Yeah, if you like. But while you don't need to vote, you don't need to vote yet. Because, yes, you will. No, we will have the discussion. And if you've been convinced by the discussion that you will vote, then you vote. And in the end, the rest votes if they have not finalized. So, any comments from the panel? Yeah.
Yes, just a comment. Obviously, you can't have like a blanket rule for whether you have to do nail the ostium or you have to do a inverted provisional. It all depends on the anatomy and the wide angle. Obviously, if the anatomy is suitable, you can sometimes nail the angle as well, and also with the imaging to see how the plaque, is it involving the true ostium, and is it extending into the left main or the LAD, and that will decide which technique to use. So I think it should be patient-oriented and tailor-made for the individual patient, and there will be cases where you can nail the ostium. In some cases, I think inverted provisional might be better. So it's not one or either. I think both can be used depending on how the anatomy is and what the intravascular imaging is going to tell you.
You see, basically there is a problem with restenosis. Yamamoto published 48 cases, I think, in JACC. There were two major things. One is the new internal proliferation, and one was the stent fracture. Now, I just wanted to know, between these two techniques, inverted provisional and nailing the ostium, which will have more stent fracture? That's it, because there's a lot of movements there.
I totally agree that there is no one-fits-all technique. So it needs a very precise analysis of the anatomy. And another comment to the technique, what recently has arisen is the live IVUS guided positioning, which really works fine. You take the IVUS in the LAD and position live under live guidance the stent in the ostium, and this really works fine in practice.
Dr. Kumsars, final comment, and then we vote.
I also absolutely agree. It should be individual approach in every case, depending of how big is difference in diameters from third to left main and angulation. So it's good to know both techniques, definitely.
Thank you. Now take your phones, scan. Okay, I think we should stop. Can we see the result? So 52, not sure, circ only 23. Maciej, you are much better than we expected initially. Okay, I think now we switch to second topic. Bravo.
Thank you very much.
Okay, second topic. Main focus on the ostial circumflex in left main stenting, Medina 111. Beatriz? She's not here? Ah, it's recorded. Okay. Listen to Bea. She was here yesterday.
Good morning from Barcelona. I'm Beatriz Vaquerizo, and really thank you for the invitation. I'm going to present two cases. The first one is more ABC main strategy, and the second one is a more contemporary strategy to left main bifurcation lesion. You can see here a distal left main, 1-1 medina, no complex distal left main, short lesion in the left circumflex, no diffuse disease, no calcification. So we use IVUS before because we wanted to know the distal and proximal basal reference diameter, also the lesion left, and also we analyzed the plaque characteristics and distribution for the left main. So radial approach, 7 French, 3.5 cutting balloon because was a fibroelastic lesion. Then we implant a stent, left main, left circumflex, crossing the left main LAD, crossing the circumflex. The stent was according to the distal basal reference diameters, and we did POD with a non-compliant balloon for optimal apposition, the proximal part of the stent, according also to the IVUS information. Then kissing balloon according to the distal basal reference diameters, 3 and 3.5. Now we use shorter balloon, but in the past we used 15 millimeters balloon. And then we perform IVUS. This is the most important part because we want to check a position of the stent, expansion, dissections, and also stent geometry at the level of the carina. That is important, and sometimes it takes a little bit of time to analyze the expansion, but I think more and more the softwares are really easy to use. So here you have the final result, you have the IVUS final result, and also we have the long-term follow-up because that patient came to the hospital because type 2 myocardial infarction regarding atrial fibrillation. So, and you can see that the ostial of the left circumflex was similar to the final result. And this one is a more contemporary approach. You can see this is STEMI patient with a left main bifurcation lesion. We cross with a wire and then we implant a balloon pump because the patient wasn't stable. I cannot show you the IVUS imaging because we lost because it was the portátil machine. So I'm not sure it was not safe, but we pre-dilated with a small balloon. And then we according to the IVUS, we choose a bigger balloon and then we implant a stent, a long stent, left main LAD. We perform a POD, then we repeat IVUS and we realize that we needed a bigger balloon for the left main. And this is the final result after POD. So we see that there was a severe stenosis at the left circumflex. In that cases, we wanted to do a kissing balloon and we prepared for do a drug-eluting balloon for the left circumflex. So we did the first kissing balloon with a small balloon in the side branch, now shorter one, and then we use a more long balloon and bigger balloon to prepare the vessel for the drug-eluting balloon. And here you can see the depth, the drug-eluting balloon, inflation 1 minute at least, and then a non-compliant balloon in the main vessel, and then finally with kissing balloon. And you can see here the final result. The operator didn't do IBUS. In my opinion, this is a mistake. Despite you use IBUS before drug-eluting balloon, it's important to use IBUS after drug-eluting balloon. You can see here the 6-month CT scan. We saw moderate to severe in-stent stenosis. So the patient the angiography was performed in another center, and you can see here the stenosis in the left circumflex was quite good, was similar to the final result, was a moderate lesion, but was a severe distal left main lesion with FFR that was positive, and the patient was sent to surgery. So my conclusions are, if there is no complexity in the distal left main and is a true bifurcation lesion, I think EBC main strategy, provisional T-stent with mandatory POT and recommended kissing balloon and IBUS pre and final is a really good strategy. Maybe DEB could improve the results in the side branch, but at this moment we don't have data. So we need to follow that patients clinically, and I think, in my opinion, by imaging. Thank you so much.
Thank you. Thank you, Bea. And second presentation by Gábor, 2 stents up front in true left main bifurcations. And then we discuss.
Thank you very much. So I was asked to summarize the pros and cons for 2 stent upfront strategy for true left main bifurcations. So when we see this on the angiogram, we have to understand there is a kind of mass of plaque behind what we're going to treat. And for that one, there is one way that we say that we put only 1 stent, or one could consider that maybe it's better really to cover, to scaffold, and to deliver drug to all over this plaque. As Jan said, that the ostium of the side branch is the kind of Achilles heel of a bifurcation strategy. So one would consider that if it is the Achilles heel, then take a booth and cover it. So there are some research data suggesting that actually if in a side branch you have extensive disease, then dual stents might be better. And also if you look at the left main anatomy in the long-term follow-up of EBC main, which sounds equal for the provisional and dual stents, but if we look closer to different anatomic settings, like the extent of the disease in the side branch, then there is some data suggesting that dual stent might be better if the extent of the disease in the circumflex is more pronounced and if the side branch is bigger. But we have to understand that if you want to go for 2 stents, there are always some drawbacks of these techniques. We have a whole portfolio of double stent techniques, but all have pros and all have cons. These stent techniques sounds very simple. You can say it fits all diameters and mismatches, but we have to admit it leaves a gap which is not scaffolded. So, problem. We can go for tap stenting. It's simplistic. It's not that simple as we think, but it sounds simplistic. Might fit all diameter mismatches, might provide full coverage, but it results in an ocarina. And as we discussed yesterday, it requires a perfect projection, which is not always the case. You can say that, okay, we go for DK culotte, which, wow, we have full coverage, we have no neocarina if performed properly, but we have issues with diameter mismatch, we have issues with the double layer in the left main, and whatever we say, it is more complex than the others. And one might say that DK crush is the technique for saving the Achilles heel of left main, but although it provides full coverage, there is no neocarina, fits all diameter mismatches, but it definitely has a massive layer of struts and is definitely more complex technique. So if you want to summarize these ideas, then on one hand, we have good rationale behind covering the ostium to avoid this, but if we want to treat complex bifurcations, and we want to have a technique which fits in ideal on all means, we have to also admit an ideal technique does not exist yet. Thank you.
Thank you. Before voting, discussion. Kristina, you want to comment?
I'm glad that we talk more and more about drug coating balloons. I remember 10 years ago, Goran, if you know Maja Stroci, and I wanted to talk about it, and it was a big no, because what would we do if we have a relatively easy solution for bifurcations? I think today still the provisional is a good choice. You have today many tools for lesion preparation, and I was an OCT and can really help us to decide and to have a good result with provisional stenting as well.
Thank you. Anybody?
Again, maybe not hard statements, but at least for me, if it's possible to achieve good, acceptable result with one stent, it's definitely better. But from other hand, there is case where you have to go for 2 stents. So.
To the same comment, I think I might say something controversial here now. So not all Medina 111 are similar. So if the side branch is extended disease, like more than 10 millimeter, and diffused, and sometime following the philosophy of EBC, doing a provisional may not be a good idea. And we go for 2-stent strategy because there is some data to support that T-stenting or tap stenting is inferior to some of the dedicated 2-stent strategy in some patients. So what do other members feel about this?
So actually at this stage we can use drug coating balloon or lesion preparation devices. So at left main bifurcation, actually the diameter required for stent at polygon is much, much higher compared with left main diameter. So first, for me, it might be better to use some lesion preparation device and provisional stenting.
Anybody in the audience wants to comment? Should we vote? Yves? Okay, just don't focus on what Yves suggests. Scan and let's vote.
And maybe you should display the results on the screen so we can see how they come in during the voting. Can you do that? Our entire panel actually say that there's not one thing that fits all. So I think it's fair. But remember, what is the preferred technique? So there is actually a distinction here. So, have everybody voted?
Okay, I think we have clear answer at least for this one.
Yes. Very good. But then I think we should move on because there is yet a vote to come up, and I think the last comments about the drug-eluting balloons is actually very, very fit to move on with the next voting, which, of course, the new animal or the new kid on the block, drug-eluting balloons, they do have a role here. We don't really have the evidence, but how do we actually see it at the moment? So help us here, Nicolas Amabile, deb in the side branch before stent in the main branch? Question mark.
Thank you, Jens. Thank you for this challenging invitation. There were a lot of debate during this meeting about the role of DCB for ostial circumflex, and the question of putting a DB in the circumflex before stent in the main branch means that want to think about the best way to apply the hybrid approach. This hybrid approach has been suggested to be effective by this publication from a Chinese group that suggested that the clinical outcome could be better if we use a DCB in the ostial circumflex compared to DES. We also, Francesco Tartaglia reported previously the result of the DCB Circo registry that also compared DCB PCI versus DS only PCI for this de novo ostial circumflex lesion. And it appeared that in this series, 27% of the patient benefited from hybrid provisional strategy, and the clinical outcomes were quite comparable. So what I was asked to do is to think about the best sequence to apply for this hybrid approach, yet we don't have very strong clinical data to support it. However, I think that there are pros and cons, and I will try to think about the theoretical advantages. So, of course, the hybrid strategy has some advantage. First is to avoid too much metal in the carina on the distal left main, to avoid long stent in circumflex in case of long lesions, and maybe to avoid some stents in some stent-unfriendly lesion with high angulation of the circumflex, calcified nodules. And so if you go for this hybrid strategy, it's better to first apply the DCB to the ostium of the circumflex. And there are some probably theoretical advantage to do it because, well, we know that this DCB approach will involve a preparation of the lesion. It can involve non-compliant balloon, cutting balloons. Even we saw some cases with rotational atherectomy or IVL. So probably that the delivery of the DCB, which is also a device with a quite limited profile and compared to conventional balloons, so the delivery of the DCB and these preparation devices will be more complicated after the initial stent placement. Second, we can have some questions about the best dose of the drug delivered to the ostial circumflex. If you apply the DCB first, you can expect to have the optimal dose of drug delivered to the vessel because the DCB will move freely towards its target. However, if you redo the same kind of analysis of approach after a stent was placed, it means that your DCB will have to cross the metal of the stent, which can potentially damage the coating, and we don't have any idea about what is the actual dose of drug that will be delivered there. I think it's quite unpredictable. So we don't know, and in this perspective, maybe that putting the DCB first will be more appealing. But of course, there are some cons. The first one is that, as you know, you might create a dissection in the ostial of the circumflex. And in case you have a dissection before putting any stent, in my opinion, that will involve to stent the side branch first. What is the risk of side branch bailout stenting in DCB strategy? According to the different papers, this risk ranges between 4 and 7%. And of course, in case you have a dissection in the ostial circumflex before treating the left main, I think it will be safer to go for DKK culotte or inverted T-stenting, and so it will change your strategy, of course. So it means that you will end with a two-stent strategy. And at last but not least, we don't really know if there is any influence of the final kissing balloon inflation or ostial balloon reinflation in case you go for pod side repod strategy. If you reapply a kissing balloon inflation after you put the stent in the main branch, will there be an impact of the side branch redilatation on the biokinetics of the drugs after the DCB application? We don't really know. So, to conclude, the best management of the ostial circumflex is still to be discussed, and it's a story that has to be continued. Thank you very much.
Thank you very much. And I think we do have the next presentation on video.
Thank you very much again for inviting me to this session. I think we are almost closing this year EBC, and I'm very happy to participate as well in this exciting session about the ostium of the circumflex, which, well, is, as you all know, it's a complex segment to treat, and perhaps the origin of many, not to say most, of the TBRs after left main stenting. So My position is to defend the use of DCBs in the side branch, specifically in the circumflex, after main branch stenting. And I think Nicola have defended the position of doing before stents. And then I think, thank you very much for giving me the easy topic, because I think I can, I agree with this philosophy. And if we think about the whole philosophy of the club, I think we all agree, and the trials have demonstrated that a stepwise provisional approach is the standard, or should be the standard approach for most left main bifurcations, and that is supported by an amount of data. But basically, I just want to quote the recent publication of the EBC main showing basically equivalence of provisional versus the stent. Nevertheless, when we look at the ostium of the circumflex, this is the Achilles heel of left main PCI. And you see here, this is a series from Italy showing that 1 out of 4 patients come back for a TVR after treatment of the circumflex, and that can be either with crossover or with ostial stent or whatever. It doesn't really matter the treatment. This is the place where I think PCI fails the most. And it appears that there is a correlation with flow, in the sense that when you look at the target vessel failure, is clearly determined by the severity of the disease when you look at that in terms of physiology. And I think this type of study basically separates what would happen in terms of the circumflex if you have preserved or not flow. Now, in terms of when to apply DCB in the ostium of the side branch, well, I think that the only randomized evidence that we have today comes from DCB bifurcation trial, basically applying a DCB, which is just a carrier of drug after the vessel has been prepared, after the stent has been placed in the main vessel, and then you see the result in the other vessel. And again, there is absolutely no reason or evidence to suggest that before stents will be beneficial. But if you think about it, why would you do before stenting? And you might say, well, because it looks severe, and I want to start the procedure pre-dilating both branches. Well, I think you have to rethink this approach, because most of these ostial circumflex are certainly not severe. And when you look at the data, this is coming from Korea, showing that when the left circumflex has a diameter stenosis more than 50%, and you might think that it's significant, actually less than 20% of those are really significant. So I think that this is a segment of the coronary tree that, again, you need to be certain that it's significant to be treated. But again, now moving to when, I think, of course, committing to doing that upfront has some risks. And again, if you start by dilating, this is a case where we pre-dilated the circumflex, and then you see here, basically we had a dissection, flow-limiting dissection, and of course, what was a stable procedure becomes something completely more complicated. Now, in terms of the efficacy of the DCB, DCB requires that there is one drug retention, and that the drug is homogeneously distributed in the tissue after the inflation. And this is what you want to achieve. Now, if after you have done that, then you keep ballooning, because then you have a pinch in the ostium of the side branch, then you will basically stripping off the drug that is in the surface of the vessel. You will likely clear areas where you will make the drug that is in the vessel kind of wash down the coronary, and that could actually lead to less efficacy of this treatment. So DCB should be the last therapeutic step in the side branch, specifically the bifurcation. And I think this aligns with the stent the main branch first, and then assess the side branch and decide what to do with that. So the key points for my presentation, and looking forward to the votes, is the EBC endorsed the stepwise provisional approach for the treatment of most bifurcations. And I think that DCB fits naturally in the step of the provisional approach where you are going to assess the side branch. And then if the side branch is pinched and you have low FFR, DCB it. If not, leave it alone. And I think from the more philosophical approach, I think that doing DCBs only if needed after you have placed the stent in the main vessel basically fits completely with the philosophy of the club in the sense that do only what is necessary. And thank you for your attention.
I think this makes more sense to use the DCB after the main branch is stented, because that goes in with philosophy of EBC recommendations also. Because if you use it beforehand, then you have not followed those guidance, and then you will be ready to stent the side branch first and then the main branch. And I don't think there is much data to support that the drug is lost during crossing. Obviously, you only put the drug-coated balloon to the side branch if you are planning to do a kissing balloon. If the bifurcation looks okay after the pot, then you don't do it. And if it doesn't look good, that's less than 50% stenosis or the plaque shift, then you recross and do the DCB and then drug coat and then a kissing balloon after that. That goes in with the flow of what the data supports.
Also, the balloon is folded. The drug is at the surface of the folded balloon. But it's also inside the folded part of the balloon. So when you are opening the balloon, you are putting the drug on the wall. And also a second argument is that when you are using the provisional, you need to put a stent. Sometimes you have difficulty to put a stent in the side branch. It was said with long lesion. Long lesion means that it was not well prepared. So when it's well prepared, there is no reason to damage the drug-eluting balloon if the lesion is really well prepared.
And the new generation drug-coated balloon, the manufacturers are taking extra effort to put the drug inside the fold, so it only gets exposed when the balloon is inflated. And the balloon quantity, there's a lot of drug on the balloon. You don't need all that drug. So there's still enough drug on the balloon, so loss is not a major problem because there's extra drug on the balloon.
Yeah, there is definitely some scraping that happens, and especially we have tried to put into the circumflex. So your main stent has to be really very well deployed, and the ostium of the side branch has to be fully open, fully circular. Not a single strut or a crown should be adherent in the rim of the ostium for the balloon to pass very easily. Secondly, the drug-coated balloons don't behave like normal balloons. They are stiff. They don't go so easily. So if there is little calcium or tortuosity, you are going to encounter a problem. So as a routine strategy, I deliver the drug first, stent the main branch, and then maybe do a kissing or a opening.
Sudhir, there are some companies which put drug before folding balloon and some put it after folding. Does that make difference?
Yeah, it may make difference, but the bench test and some animal studies, they have shown that the amount of drug which is released into the tissue is about 20-30%, because some is lost in the transit also. Yeah. So you can't avoid that. That's why the stents.
Dear Chairman, thank you for the invitation.
So therefore, the stent, like Dr. Bhagwat is saying, the stent strut should be well opened before the drug coating balloon is taken. So it's not like you have to open the stent strut with 2025 balloon and then take in the drug coated balloon. But if you take it without opening the stent strut, then you run the risk of damaging the balloon.
The drug. Yeah, Gábor.
Most of them
wait a second, Gábor.
Yes. So our argument for doing the DCB after treating the left main and main branch, especially in setting of left main, because once the stent is already placed, the left main is already large enough, so you can protrude with the circumflex DCB into the left main. It's not occlusive because it's already treated. So you can freely inflate it for 1 minute. It doesn't cause a complete flow compromise to the entire left system anymore.
Yeah. Most of the new generations drug-eluting balloon, releasing balloon are folded, so it doesn't. You don't lose drug basically.
So yeah, okay.
Yeah, especially the drug loss in transit was a problem with all the previous drug-coated balloons. But now Solution ER, when you speak to the company, the drug loss is minimal in transit, and the drug delivery there is almost 30-35%. So 35% drug is possibly what is optimal. That's what your data says.
Yeah, so again, we have what we want, a very intense discussion. And it was actually, of course, sad that we couldn't hear Carlos, but it triggered a discussion that is very nice. But if I have to extract something out of this discussion, it is the same advice we got from the audience, or from the panel in the two other votes. Not one technique fits all lesions. So we are actually back. And there's a lot of things to be considered. But I think if we should summarize what Carlos actually was saying in his last slide, it was, if you go provisional in the originally way, traditionally advocated by the European Bifurcation Club, then you go stepwise. And then in an end, you have a provisional stent, one stent inside, and then you have to reevaluate the side branch. And if this is the strategy from the beginning, then it's wise to go after the first stent, because then you just build in yet another step in the provisional pathway to avoid the second stent in the side branch. That has caveats, of course, as we have heard, because maybe the drug will actually not be that effective if you cross, depends on the design of the balloons. The other way around, the before thing, which Gábor so nicely told us, is stent the side branch first. No. DCB the side branch first, and then see how the session actually emerges after that.
Can you give microphone to our guru, Prof. Kleber? Nicolas, go ahead, and then I like final word from Prof. Kleber.
Well, almost all cases we did over the last 15 years were with the DEB before the stent in the main branch. So I think we have the largest, of course, non-randomized database on this technology. And we will have at our symposium in November on DCB, we will have data that it's difficult if you re-entry the vessel after the DEB. This is the other side. So hard to say, but the largest database is on DEB first.
Thank you. Nicolas, and then we vote.
Yeah, I think probably it's just a matter of, as we discussed with Gábor, it's all about the angulation. If you have a narrow angle, then it will be very straightforward to pass the DCB through the struts and go into the ostial circumflex, and then you can expect very few damages. But in case of really high angulation, then of course it will be more challenging, and maybe that in this case we might consider DCB first.
Thanks. Let's vote. This is so far the most challenging one, 50 versus 44. Prof. Kleber, you need to come next year again, so not enough teaching.
And there's another thing, it's so good with the DCB club, because now we really have a forum where we can discuss DCB in details and bring it into this environment afterwards. So I think this vote actually shows us exactly that the question is a little bit open and we need to understand and learn much, much more. But
63 people voted.
So yeah, can we end the voting?
Yes.
Yeah.
64.
Good. So by this, thank you very much for participating in this setup, which is it's a little bit new, but we actually choose it to focus on the discussion. And thank you very much to the panel, and thank you very much to you, Goran, for leading this with me, because it was not that easy. And thank you very much. By this, we'll close down this session, and this is actually a new thing, so we have made a record. So just please share with me, for the first time in the European Bifurcation Club's history, for 21 years, we end before time in a session. So let's just celebrate that a little bit.